So for the next talk, I would like to introduce Dr. Samara Zavalkoff, who's done a lot of great work in this topic. She is an associate professor of pediatrics at McGill University and director of safety at Montreal Children's Hospital. And she's going to talk to us today about preventable harm in the Canadian OTDT system, missed organ donor identification and referral. Samara has her own Slido there, and she's going to basically take all the questions from you. And so we just ask you to ask questions over Slido only, because it would be hard for her to access the room. So I mean, I don't have to do anything but get out of the way. So take over there.
Hi, everyone. Just to be clear, I have some quiz kind of questions that are part of discussion on Slido, but I don't know that I'm going to see your questions on Slido. So I think I have access to the chat. A number of you responded to me if you could hear me there. So you can put them in that chat and we'll manage that way. Thanks for having me. I'm sorry I couldn't be with you in person. A number of us just got back from the big international meeting in Las Vegas over the weekend, but I'm glad to be here virtually. And this Slido, you can log on through your laptop or your cell phone. And this is the code so that when we get to the part later of the questions, then you'll be ready to go. I'm just seeing in the chat yeses, but yes, people can hear. Great. Okay. So just to make the disclosure, I did receive funding for a lot of this work that we're going to talk to you about today from both Canadian Blood Services and from Health Canada's Organ Donation Transplant Collaborative, really focused on quality improvement in donation research. And what we're going to do today is three things, hopefully. Move along to understand that missed or delayed referral is a patient safety event. And I know this is a different way of thinking about it, but it's really a concept that I want to convey through to you all today. And then, of course, help you recognize your role in improving the identification and referral of organ donors, which many of you do as part of your day-to-day work. And to reach that end, to talk a little bit about the national clinical trigger that we've developed in collaboration with all of the ODOs in Canada so that we can all work together in a synchronized way to identify potential donors. So before I get to this personal disclosure, I just have to say, I love hearing Shelley Deb speak. I've heard her speak many times. It's not an easy act to follow. So we're all very lucky. I don't know if Shelley is still there to have started your day with such an inspiring, honest presentation. And I totally agree that we're all a work in progress, and that includes this work, which is a work in progress. And we're all looking at not just what we need to do better, but what do we already do well that we want to be deliberate about and continue to do well so that it recurs in that right way over and over again. So it's a little bit like those lists that Shelley talked about, for gratitude. So this is the other personal disclosure, which is that I'm not really a donation expert, and maybe that applies to Shelley as well. But interestingly, we've been asked to come here and to talk to you. And in my case, what I am is a patient safety expert. And then I, through that lens, got involved in a lot of donation work. As you heard, I'm the medical director of patient safety at the Montreal Children's at McGill University. And what that means on a day-to-day is that safety events happen. They're brought to myself, my team, and we have this reactive response to them where we look at why they happened, we investigate them, we analyze them, and we try to put measures in place to prevent them from recurring. And then there's a whole proactive part of what we call our program, which is mission safety. You see the logo here, which is building a safety program, setting structure, governance, priorities, doing projects that further all of those objectives. And what I realized is there's really a lot of similarities about safety work and donation work. But I'm going to start first by telling you a safety story, and it's just an example story, and you have your own stories if you work in the clinical milieu. In this case, it's a story of a baby, a 6-month-old baby who presented to the emergency department with a high fever, difficulty breathing, viral illness is suspected, and the child needs oxygen. So she's admitted to the hospital. She's quite irritable, and it's difficult to obtain vital signs on her. But when the heart rate is recorded, it's very high. But of course, she's crying and she's febrile, and it's not always easy to obtain an oxygen saturation. But she's also moving a lot, and so maybe that's part of it. But essentially, over the next 24 hours, this baby becomes more tachycardic, more tachypneic, needing more oxygen until code blue is called on the pediatric ward when the baby loses consciousness and they can no longer obtain a blood pressure. Resuscitative measures are successful, thankfully, and she's admitted to the ICU where her blood cultures grow bacteria, and it's clear that this baby had a period of deteriorating vital signs that was under-recognized from septic shock. So I'm telling you this story to show you a model of how we respond to a safety event. So in our safety program, the first thing that happens is we do what's called an executive huddle. So our head physician, nurse, CEO, myself, people primarily involved in the event, we get together and we make sure of a number of things. Is the patient now safe? Is the family supported? Is the team supported? Because everybody knows when you're involved in an event like this, it's traumatizing to everybody. We do an immediate categorization. Is this, what level of safety event is it? We do an immediate analysis with the information that we have so that we can put in place immediate interventions to safeguard the system, the next patient. And already within this first 24 hours, we start to plan or perform a disclosure with the family. And you may all have something, similar systems. So now I want to tell you a different story. And this is a donation story, so something that you'll be more familiar with. So this is a 9-year-old boy who presented in end-stage heart disease. He had been previously well. And when he deteriorated, he went onto this device, which is called the Berlin heart. It's an extracorporeal mechanical circulatory device. And it's attached, as you can see here, to this large box that's on wheels with the computers and the programmer, which means that a child like this needs to stay in the pediatric ICU. And in the case of this boy, stayed in the pediatric ICU a total of 14 months, 10 months on this device. The story has, a story like this has its side effects, consequences, both in terms of cost, because one patient on a device like this equates to, on average, about 30 ICU admissions, and cost the system about $1.6 million a year. And those are just the costs that do not include physician or surgical costs. And what's even more important is that the Berlin heart is not a perfect treatment. The survival of children on it to transplant is 60 to 70%, which means that there are a large portion of children that will never make it to transplant. Even without Berlin heart, we know that there is a certain mortality of being on the cardiac wait list, both for adults and for children. You can see the figures there, up to a quarter of adult patients, up to half of pediatric patients. And this is because children or adults will die waiting from complications, or they'll be withdrawn from the list because of those complications that now make them ineligible. Thankfully, the story in this case ended well, and this boy was transplanted after his long stay in hospital and went home within 2 weeks. So why am I telling you this story after telling you about a non-transplant donation story about a safety event? So I want to rewind and tell you what happened 2 days before this transplant. So 2 days before, another child somewhere else presents with a devastating brain injury. His intracranial pressure is refractory to all medical and surgical therapies, and his prognosis is deemed to be quite dismal, and his family is met by the clinical team who explain the situation, and the family understands, and they don't want their child to suffer anymore. And so they discuss with the team the plan to withdraw life support, which they organize to do for the next day so that they can spend the night with family and friends, saying goodbye. And in the ICU, normally the physician would have carried on through the night and been the one the next day to withdraw the life-sustaining measures and support the family. But in this case, there was a change to the call schedule, and a different physician came on for the night and asked the team the question if this patient with the devastating brain injury had been referred to the organ donation organization. And the answer was no, and hadn't come up. So the referral was made, and the family was met by the donor coordinator, and I'm sure many of you have been that person, to present the options to the family. And this family was highly motivated to be a donor family. And they consented to donation after death by circulatory criteria. And over the night and the following day, while preparations were being made, the patient actually progressed to brain death. And so it turns out that this child is the perfect match in terms of blood group, ABO, as well as size. And that is why this other child that we started with on the Berlin heart had a successful transplant. So in your world, in donation, this story would be called a successful transplant. In my world, in patient safety, this would be called a near miss. What is a near miss? It's a safety event that doesn't reach the patient and doesn't cause them harm, but had it, and it could have, it would have caused significant harm. And we like to talk about near misses because we like to learn from them, because we got lucky this time, but next time maybe we won't. And so we want to learn from those events to make sure that they never reach the patient. So let's imagine that that call schedule change hadn't happened, that that physician nor anyone else would have raised the question of referral. That would have been called something else. So in your world, that may have been called a missed donation opportunity, and we're going to come back to that. And in my world, that would have been called a serious safety event. So let's just backtrack to some information that you already know, which is that there are many people in this country waiting on the transplant wait list, and the number of donations that we do, while they have increased and improved over the decades that you have all been working in this field, they still do not match the need. In addition to the Delta, which is almost 3,000 people who continue, 3,700 more people who continue to wait, there's a number of people who are on the list who are either delisted, and that number is very difficult to quantify. And in 2022, the 270 people who died on the wait list. And that's that number that we're all aiming to reach, so that eventually all of the demand is met. And what a lot of people don't understand and don't think about, when they're signing their cards and they're seeing the need to sign cards, which is of course important. But the real issue when it comes to identification and referral is that we are starting with a needle in a haystack that I'm going to just walk you through here. So this is the total number of deaths in 2022 in Canada. And then that's the number on the left side of hospital deaths. And then we get into this bottom left-hand corner of who's actually a potential donor. And obviously it's getting to be a smaller and smaller portion. And then a smaller portion is the utilized donors. And these are our final number of donors in the different organs. And because on average, they donate 3 organs, but up to 7, that's the number of transplants that are performed, which is 2,936. And you can see behind the over 3,777 that are still waiting. And those that are withdrawn, and those that die in the wait list. And I tell you all this to just compel why every referral is so essential. And we know that not only does donation save lives, as we see here, this is something that as a non-donation person, I was shocked to learn when I got involved in this work. I figured dialysis was a way to extend life indefinitely, but in fact, the 5-year survival for dialysis rivals some of the worst cancers at 45%. And when we sit back and we compare it to what the 5-year survival is for that same patient who has just had a kidney transplant, 92%, we know that we're doing not just something that feels right, but something that is truly life-saving. And that also costs the system less money, because after that first year of transplant, when we compare to dialysis, the system is saving between $33,000 and $84,000 a year. So there are all of the compelling reasons why transplant is the right thing to do. And so when we go back to that case, as I said before, if no one had made that referral and that other child's donation could not have resulted in the transplant for the boy on the Berlin heart, maybe you would have called it a missed donation opportunity. But in many centers in our country, we would have actually called it nothing at all, because we wouldn't have known. And then, as I said, in my world, we would call this a serious safety event. So what is that? So a serious safety event has 3 criteria. The first is, was there a deviation from standard practice? Second is, did it reach the patient? And third is, did it cause harm? So let's look at this case and let's decide together, analyzing whether it's a serious safety event. And just to say, that term, serious safety event, is a newer term for what some of you may have known to be called a sentinel event. So was there a deviation in practice? So I would say yes. I think it's quite standard of care that we expect that people that at the end of life in this country get referred to the organ donation organization. And a big part of that is because they deserve the option, and one might even say the right, to make a decision without us imposing bias or decision for them. And even to take it further, there are in this country several of your provinces where it's actually legislation. There's mandatory referral, so that you at the ODO can check whether the patient has registered their intent to donate, verified eligibility. And this legislation exists in many other countries as well. So it's standard practice, but it's also in many cases the law. The second question is a little trickier. So did it reach the patient? So in the case of the baby who has severe sepsis and the deteriorating vital signs aren't recognized, that lack of recognition reaches the patient, that baby. What I'm asking you to do now is something very different, which is, did it reach a patient? And this is a nameless patient, maybe a faceless patient, somewhere else than in front of you. But when we miss the opportunity to talk to a family about donation and for them to possibly consent to it and follow through to be a donor, there is a patient somewhere else that's harmed on the transplant wait list, potentially. So I would argue that although we are all trained as frontline workers, that our duty of care is to the patient first that's in front of us. And we don't think a lot about downstream consequence and people in other locations. And we did learn to do this more in COVID when we had to manage surge and manage ICU beds. But we need to, I think in the context of donation, do it more regularly. And the third question is, did it cause serious harm? And I would argue that it does, both to 2 or 3 people who are denied the opportunity for a life-saving and life-enhancing therapy through transplantation. But again, also to the patient and the family at end of life who deserve the opportunity to donate, and we deny them that when we don't make the referral. There's 2 other little checks just to go through quickly in terms of calling something a serious safety event, and that is that it has to meet the criteria of being preventable. So if we do everything, we make the referral, we approach the patient in the best way we know how, and the patient or the family declines the donation process, that's not a serious safety event because it's not a preventable issue. We've followed standard of practice and the family made a decision. If a patient has significant bleeding from a surgery that's known to have bleeding and they die of bleeding, that's called a complication. It's not a serious safety event. So that's one caveat. And the other caveat is this notion of, is it a system or a person problem? And in patient safety, we want to identify when things are a person problem, when, you know, the system is done everything right, but one of us in the system has not done our job. And that is much more rare than the being a system issue. But it's occasionally the issue. And I'll just show you as an example, this algorithm to determine if it's a system or a person problem. So, you know, if someone comes in and they're deliberately doing the wrong thing, a harmful thing, or they come to work and they're mentally incapacitated, or they're intoxicated, or they truly had no guiding safe operating protocols or learnings about how to do the right thing, then one could say that this falls to a person problem. But most of the time, this is not the case. And we all work, as Shelley said at the end of her presentation, as good people coming to work, trying to do the right thing in a system that sometimes doesn't set us up to do the right thing. So it's a bit provocative, but I'm going to put it back to you that had that patient not been referred, and we've concluded over the last few minutes that that is a serious safety event because it doesn't respect standard of practice, it causes harm, and that harm is severe. Why do we not, as a routine in the donation world, do an executive huddle, categorize it as a serious safety event, ensure immediate support to the team, the family, do an analysis that doesn't take many, many months, put in place immediate intervention so that the next identification and referral goes better, and even potentially disclose it to a family. And that's what I want you to think about. And this is exactly the kind of message that we put forward in this paper in 2019 when we met a large group of us at this potential organ donor identification and system accountability meeting, and put out this expert guidance. And I won't read out there were many other pieces of advice, and these were 3 of them that relate to missed donation opportunities. But just to pull the highlights out is that we all should be committed to minimizing missed donation opportunities, identifying them as safety issues, and reporting them and investigating them, and having a system in place for accountability. So like any other safety event, we do a review and we figure out what can be done better the next time. And again, as we said, that accountability is both to the family and the patient at end of life and to our patients that are awaiting transplant. So this is the summary of this concept. And now after this, I'm going to shift gears and tell you what have we been doing to try to move this into improvement in terms of reducing missed donation opportunities. So in summary, missing a donor causes harm. It is a recurrent and system problem. I would be surprised because every time I do this, people say this happens in my institution. I have seen it. This is not a rare, never happening event. And I'd be surprised if you don't tell me the same thing from your experience. It's standard of practice, and in some cases it's the law. And we know that doing this right leads to transplantation that saves life, improves life, and saves money. And so I really hope that you will think about couching a missed donation opportunity in this way. So I want to focus on identification and referral. And as a process person in patient safety, it just makes sense, because if you're carrying out a process and the first step isn't maximized, it matters a little less in my mind what you're doing downstream if you're not getting as many people into the first step as possible. But of course, yes, we can have missed donation opportunities after identification or referral. We can have them in how we approach people and when they consent, and how we manage donors at end of life, and how we declare death, both in terms of neurologic criteria and circulatory criteria. And you see the new terms here, but let's talk about identification and referral. So you're going to join Slido, and bear with me that I don't mess this up too badly. So hopefully you have a minute to have linked into slido.com and put in the number you see here, 2403779. And I'm going to switch to the other screen. So hopefully now you see this. And you can start answering this first question, which is, are you clear on when you should be referring a potential donor? Yes, no, kind of, sort of, maybe. I feel like kind of, sort of, maybe is my answer to almost everything these days. Great, so I'm going to give you one more minute there. Amazing, great engagement, guys. Okay. So we have a almost even split between the yeses and the kind of, sort of, maybes, and some no's as well. So what tells me is we haven't done this perfectly yet, and those who said yes are going to help the kind of, sort of, maybes and the no's of us get there. Okay, I'm going to switch us back here. So this is just to sort of set the tone that, you know, we're not all here for no reason. If we all said yes to this, then I could probably just end it and you guys could have a longer break. You're not in poor company, those of you who felt that this is still a challenge, and this is just some evidence to show you that you're not alone. So this was a really nice study that Christina Krompottek did with this research group on delayed referral that resulted in missed donation opportunities after circulatory death in Ontario. And what it showed is that there was 35% that got, you know, referred before any initiation of withdrawal of life support therapies. But then there's these other patients here that either get referred at or after withdrawal. And calling the organ donation organization when the endotracheal tube is half out of the mouth or already out really doesn't leave anybody the time to do the process that we all know takes time to actually approach and give someone a true option about donation. And then there was a small portion as well that were never referred. And although the numbers look small, when you look at 251 missed referrals, that's, we estimated just by Trillium's average consent rate comes to about 150 consented donors. And you times that by 3, because that's the number of organs on average that are transplanted. That's a lot of organs when we are not meeting the demand for this vulnerable population on the transplant wait list. We know this problem exists also in the emergency department. And this is some data both from Canada and the UK. Brain death patients not being identified, death by neurologic criteria, patients not being recognized. This third one always gives me pause. This is 16% of the missed referrals were actually patients who in the UK were registered. They had taken the time to register, and then we didn't take the time to make the referral so that their wishes could have been known. And overall in the UK, only 47% of potential donors were recognized. So the emergency department is a chaotic, stressful place, and this continues to be a challenge there. And we have understanding as to why this is. Part of it is knowledge gaps, comfort. This work by Jen Hancock taught us that specifically around death by neurologic criteria or DCC, we're more uncomfortable than when it comes to brain death, death by neurologic criteria. We know that education and standardizing that education is difficult, and it's uncomfortable. These are not conversations that any of us, revel in having. And then specifically physicians, it's really a common event not to refer. This work by Matt Weiss, over half of ICU physicians have reported to in this survey not refer to a potential donor, making the choice not to. And we have also seen in over 40% a colleague not make a referral. Why does this happen? All the reasons that you know. The first one being, we thought this patient didn't have the organ function to be a donor. So why would I refer and waste people's time? Family is really distressed. I don't want to add this on. Maybe there's ethical or medical legal conflicts. not going to get into this heated discussion with a family like that, or we believe that we know what they would say because of their particular background, or the family wants to leave, and so we don't want to drag out the process. And all of these seem like very reasonable reasons. Yet we know on the other side, families that say to us after, this was the worst day of my life. You told me that my husband, wife, father, child was dead or dying, and you think that you're going to make my day worse by asking me about donation? Or come years later and a family member says, did anyone ever ask you about donation? And then they say, no, they didn't, and have the guilt to live with that they never even had the opportunity to really think about that question, and now it's too late. So we're going to go back to Slido for the second one. Where you work, do you feel non-MDs or non-physicians are empowered to refer directly to the ODO? Okay, so the vast majority, or at least half, it's a no. And then there's 30% of you where maybe. Certainly where I work, I think that people may feel comfortable to raise it to the physician. Some people might feel comfortable, but to refer directly, I think that would be not standard where I work, and sounds like that reflects where many of you work. And we'd like to work towards that. This shouldn't be a secret. This should be where whoever it is that identifies that we have reached criteria, and we'll talk about those criteria, and you have your criteria in BC, and we'll look at those in a minute, that whoever that is should be able to pick up the phone. So taking that concept of preventable harm, what we did in this work was we wanted to try to quantify how much harm was being done in Canada in terms of missed identification and referral. We wanted to actually estimate the number of missed referrals there were who were eligible for approach. So, not just everybody and anybody like who was missed to be referred, but those who would have actually been eligible for approach, and then quantify that harm in terms of patients at end of life who were denied the opportunity and choice of donation, and patients on the wait list. So we went to every single ODO in this country and we said, this is what we're trying to do, and we want your data from 2016 to 2018 in terms of your IDR rates, approach, consent rates. And we did surveys electronically, and then we actually met with every ODO because it was really complicated. And that's actually one of the most important results of this work, is that only 4 ODO could really give us the data numerically for what we were after. People had many different definitions and ways of calculating it, or they didn't have data, or they had data, but it was only from when they did a pilot and they didn't have any data since. And that told us that we have a big fundamental issue in Canada, which is having consistent definitions that are national and consistent data metrics. And that became subsequent work. But from the 4 ODOs that we could obtain data from, we learned that there were, depending on the year, between 75 and 105 missed identification and referral, what we called safety events. By not referring, that was a safety event, didn't meet a standard of care. And then when we looked at medical eligibility, there were 63 to 76 families who theoretically would have been eligible for approach. Then we said, okay, well, let's look at the approach rate and consent rate for that ODO in that year for the ones who were referred, and we'll apply it here to the ones who weren't referred. So that we ended up with 37 to 41 patients who would have been approached and consented, and using that times 3 for the average number of transplant each year between 111 and 123 missed transplants. So over 3 years from just 4 ODOs, we were looking at 354 missed transplants. And when we index that to what we know in Canada is our donors per million and our transplants per million, we would have increased our donors per million, just again, for ODOs for those 3 years by 13%, and our transplants per million by the same 10 to 13%. So then getting towards the end here, we worked with you and BC Transplant, along with all of your colleagues across the country and the other ODOs to work on a national clinical trigger so that we could all talk the same language and make it as simple as possible and put the details back in the ODO's hands. When I am working in the ICU, I need it to be simple. When my colleagues say to me things like, well, I mean, he's infected, he's not going to be eligible. Well, his kidney function's off, he's not going to be, it should just be as simple as, don't think about it. Just pick up the phone, and there's other people to go through those details. So I'm going to show you what we came up with as the national clinical trigger, and we're going to contrast it to what you have in BC, and you'll see they're really basically the exact same thing. So the national clinical trigger is a patient who is ventilated, and we were specific that that could be invasive or non-invasive, and the little asterisk is just basically they could be on other mechanical support, like a VAD. And you're at end of life. You're giving end of life care, and there's a plan to withdraw or to conduct a discussion about withdrawal because you are at the end of life with this patient and their family. So you guys in BC, you use GIVE. So G is a grave prognosis. Well, that's end of life, those go together. An intention to move towards comfort care, that again fits in that second criteria. You're talking about withdrawal of life-sustaining measures. They're ventilated, that's our first criteria. And then eligibility and registration check prior to the family meeting. That's not on ours because that's not really necessarily your trigger. That's kind of reminding you why you're doing this, is that you're going to have that discussion before you go to the family, so you have all your information. So it really is the same thing. You guys are using it in a little nice mnemonic. We just did V and E, trying to make it really simple, and we can chat about this after. We wanted to just remind you of the concept of notification versus referral. So referral is what we were just talking about when we meet either GIVE or the VE. But prior to that, the ODO is always there for consultation, for information. When I have a question and I think a cardiologist can call me, it can help me, I call them and I say, can I chat with you about this case? And there's no reason that we can't use our experts at the ODO to help us navigate these difficult situations. We're not doing something unethical when we're trying to get more information for a patient and their family at end of life. So let's see how we're doing on time. Okay. So I'm going to show you a couple of cases. We'll see if we get through them all. This is a 4-month-old who comes to the pediatric ICU after an accidental drowning with a severe hypoxic injury. The physician deems that further life-sustaining interventions are futile and is preparing to have end-of-life conversations with the family. Knowing this information, what should the next steps be? And I'll take us here. Okay. So everybody is almost everyone's pretty clear that it's time to refer to the organ donation organization. But if we go back, we kind of led you easily into this one because we're sitting here talking about identification and referral. So it means you were all listening, or you didn't need to come to this presentation. But we probably have all seen the case where, again, the team feels terrible for the family. It's already been days of horror. And maybe we want to just have that end. And so let's pull the tube and put the baby in the parents' arms and end this. But again, as you all answered correctly in the Slido, we need to make sure we've done this referral in a timely manner before that withdrawal, so this family has their options. The next one. So this is a 22-year-old university student from South Korea. She's doing an international program in Canada, and she has attempted suicide and is found hanged by her mom. In the hospital, there's a language barrier with mom that's been identified quite quickly, and the parents are divorced. The dad lives in another country. Mom is here with her daughter while she attends school. The healthcare team has determined this is a poor prognosis. The father's been notified. He's been asked to come to Canada as quickly as possible. And the team begins to discuss end of life with the mom, but is worried. She's too distraught maybe to even really consider organ donation. So here you don't get multiple choice. You're going to type in some words to identify all the perceived biases that you feel may contribute to failing to refer this potential donor to a local ODO. What might hold us back from making that referral? Okay, I'm not sure if it's tech or people are shy. So I will let you off the hook and maybe we can chat about it together as a group. So same message, we have accountability, we have it on two fronts. One is to our families who are grieving at end of life, who have that opportunity and the right to make a decision about donation, but that requires us to give them that option by making the referral to the ODO. And something we might want to talk about at the end is, what do you tell families, if anything, about if it's deemed that they're not eligible? I can tell you in my personal practice that I have started to come back to families and said, I don't know if they will or won't be eligible. I'm going to make the referral because that's what I must do, should do, and I'm legally obligated to do. And I come back and I say, unfortunately, your child is not eligible because of ABC. And I've had families after the fact, months later, say it gave us peace to know what the situation was, so we didn't have to wonder. And of course, to our transplant candidates who are on the list waiting. This is a lot of information, of course, and we want to give you this guide, the Canadian Clinical Guide to Organ Donation. Some of you may know about this tool. It's through Canadian Blood Services. You can scan this QR code. It's an amazing curriculum with several courses that cover a number of topics, including identification and referral, including going through case studies, which really get at some of this nitty-gritty. So that's the first module. And then there's modules that you can see on here on different topics. It's completely free. It can be used for any learner within the ODO, within the hospital system, administrators, clinicians, learners of all types. It's really excellent. So I will leave you with that. And I will stop sharing so I can actually see some of you. And thank you for having me. Thanks for your time, your listening, and we can chat now.
So, Samara, just before we go ahead with questions, I just want to clarify that. Can you hear me first of all?
Yeah.
So I guess we were under the impression that you would be doing Slido from where you are, but for those that are online, I guess they can put questions into chat for you, and if you could read them out and then answer them so everybody here can hear. And then for those of you here, I guess you can ask questions directly here because she will be able to hear them. Okay.
Yeah.
Okay. Does anybody have any questions right now? I do have a question for you from some of a safety perspective. We certainly do have ongoing missed opportunities in British Columbia. We know that. What has happened, on the other hand, is that we at times get a lot of referrals coming through that overwhelm our system. And so we actually have families interested in donation that decline because it's going to take too long. Is this a patient safety issue? Yeah.
Great question. Great question. So first, I'll comment on the first part, which is there was a lot of heated discussion about the clinical trigger for exactly that reason. Some people said we have to make it more restrictive because our ODO is not resourced to handle this many calls, and you want people who are clearly ineligible to be referred. But in the end, we all agreed to go that way, and then to work on the other end, which is we should be resourced enough to handle the calls. The answer shouldn't be, let's limit the referrals. The answer should be, let's properly resource the system. And then your question about waiting, it's funny that came up this weekend in discussion at the transplant meeting and donation meeting in Vegas, because I see this, as I'm sure many of you at the bedside see it, this highly motivated family who just starts to break down, and then we lose them because they just can't bear the weight anymore. And yeah, I think that's a safety issue when our system has failed them. Now, there's things within that process that we can't compress. We cannot make it happen in 6 hours, which would be what they would want. But I would be very curious to see what a real process map looks like for the from consent to OR and where we can improve. And I'm pretty sure there are places in there that we can compress some time and make it a little bit more tolerable for families.
Thank you.
There's some things in the chat. Go ahead, and then I'll read the chat.
No, you go ahead.
Okay. Any studies that can be shared where families have been surveyed to provide their experience getting asked about organ donation during traumatic times? Yeah, so I would refer you to Amy Sarti's work, SARTI. She is probably, well, certainly in the country, the preeminent researcher and even internationally in doing qualitative research that involves sitting with families and hearing about their experience. What is lacking, though, is report from families who are not asked. You know, there's not a lot of ways to access those people. So we have anecdotes, but we don't have good studies on the people who weren't asked. But from the ones who are asked in Amy Sarti's work, it's really that message of it matters how you ask, it matters when you ask, it matters who asks, but people didn't resent being asked if it was done in the right way. The next one asks, what is the approach for bedside staff when a physician refuses to refer to the ODO despite being prompted? Yikes, that's very tricky. I don't know if Shannon can offer some insight as to why that would be. I mean, like any other conflict, I would hope that it's a matter of that curiosity and the openness to be able to say, I'm concerned that we're not referring this patient because this might be something important to their family, or there are patients on the transplant wait list. Can you help me understand what your rationale is? It's also a lot easier when you have required referral legislation and you can actually respond if the answer to that first curiosity question doesn't come back the way you want with, aren't we actually legally obligated? And I find having the law is the most relieving thing, because I can even use it with families. You know, I'm legally obligated to call the ODO now where we are at. You know, I don't want to be the person to say, I think you should sneak into the back room and make the call when the most responsible physician is blocking you. But like any clinical decision, I think it needs to get opened up. Maybe it needs to go to the director of the ICU or another member, the nurse manager of the unit, because I don't think that makes a lot of sense for one person on the team to block what is the right thing to do. And do I see presumed consent a solution to this problem of not referring? It's funny, we talk about this a lot, but it doesn't really solve it. Because we still have to call, you know, the ODO doesn't just epiphanize that there's a patient in the unit who consent can be presumed. They still need to be called. So I don't think it changes the work that we have to do in terms of referral. The next one says, for the ODOs across Canada, is it standard practice that the physician MRP is the one responsible for approaching the donation discussions with family prior to ODO referral, or are donor coordinators responsible for the first approach in most cases? It's a mix. It really is a mix. Moving more and more towards the ODO is the first approach. Sometimes it's, there's a term for it that's popped out of my head, but it's sort of like a joint. Whereas the MRP, you might introduce the notion that someone is coming, but you're not having the conversation. But there's still many places where the first approach is by the MRP for better or for worse. I mean, I'm a physician. Was I taught how to actually approach a family? No. I mean, I've watched people do it and hopefully picked up some skills at it. But I certainly prefer when the donor coordinator comes and we can do it together with the training that she's had. Oh, and thanks. Shannon said it's not her question. She copied it from Slido. I don't know if there are other questions in Slido that I should be looking there for. I will look and see. How many provinces still do not have legislated mandatory referral? I think we're at 5 that do, so most still don't. Do you see presumed consent? We talked about. What is the approach? Okay, that we talked about. And And what is this? Oh, language. That was the answer to the biases. So we can talk about the biases. I mean, I clearly language, cultural background, age, the parents being not together, maybe their cultural, ethnic background, religion, even.
Samara, we have a question here. Anne, do you want to go ahead?
Thank you. So when you mentioned, the question was, what do we do if the physician doesn't want to refer? Can we? So in BC, we have the legislation, but I'm pretty sure in every health authority, I know for sure in Island Health, we have a policy, an Island Health policy that supports the legislation, and that it doesn't need to be a physician that is called. And then the critical care accreditation standards, number 12, also says that we're to ask and approach families. So I would say maybe go back to your local hospital policies and see whether you feel confident enough saying, oh, well, my hospital says I can make this call.
Yeah, I agree. I think we all have the backing of whether it's legislation or policy. The challenging part is, as usual, the interpersonal, because we're all going to work together again the next day. And it's no different when, the nurse says to me, don't you think we should start antibiotics? And I say, no, I don't think we need them. And she can say, but here are the septic shock guidelines. We're still going to have a conversation about it. And how do you navigate that conflict? Can you do it together? Do you have to go up in the hierarchy to someone else? But I for sure would be the last person to say, well, if at the end of the day, the MRP is really adamant that you shouldn't, that we should all bow to that and stand down. No, at the end of the day, the right thing has to happen. We just want to find the most collegial way to get there so that we can, after that referral happens, still work together to get through the next steps. I hope that that's not a common occurrence.
I think it used to be much more common. I don't know how things are changing, but it has to do with culture and the approachability of different positions, but hopefully that is continuing to change.
Yeah.
Any more questions? Okay. That was a great talk. Thank you for bringing us up to date on that, and look forward to more of your work in the future.
Thanks for having me. Enjoy the rest of your conference.
Bye.